Hello, 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 அந்த போகுது பாருங்க நான் பேச பேச hello, hello, hello.
Hello, check. Hello, check.
pleasant evening to all gathered here on the eve of the 105th birth anniversary of our founder, legendary and beacon, above all, a remarkable human being, Dr. G. Venkataswamy. It is customary for the family of Aravind Eye Care System to celebrate his spirit of giving by having an illustrious event, the G. Venkataswamy Endowment Oration Award Ceremony. Let us start this memorable occasion with a prayer song by Mr. Sanal Joseph, a senior faculty at 𝐿𝐼𝐶o.
மன்னாதி பூதமொடு விண்ணாதி அண்டம் நீ மறைநான்கின் அடிமுடியும் நீ மதியும் நீரவியும் நீ புனலும் நீ அனலும் நீ மண்டலமிரண்டெழும் நீ பெண்ணும் நீ ஆணும் நீ பல்லுயிர்க்குயிரும் நீ பிறவும் நீ உருவமும் பேதாதி பேதம் நீ பாதாதி கேசம் நீ பெற்ற தாய் தந்தையும் நீ பிரம்மானி விஷ்ணு நீ கைலாசநாதன் நீ அல்லாவும் இயேசுவும் நீ எல்லாமும் ஒன்றான இறைவாணி என்னாலும் எல்லோர்க்கும் அருள்வாயே நலம் யாவும் எல்லாமும் ஒன்றான இறைவாணி என்னாலும் எல்லோர்க்கும் அருள்வாயே நலம் யாவும்.
I invite our passionate perfectionist, the chairman of Aravind Eye Care System, Dr. R.D. Ravindran, to welcome the gathering and speak about the award.
So good evening, respected Professor Astrid Fletcher, Dr. Ion Fletcher, Dr. P. Nambarmal-Swamy, Dr. G. Nachiyar, senior leaders of Aravind Eye Hospital, Aravind Eye Care System, the doctors, MLOPs, and the staff who work in various Aravind Eye hospitals, 𝐿𝐼𝐶o, Aravind Medical Research Foundation, and Oro Lab. It's a great pleasure in welcoming you all on behalf of the senior leaders of the Aravind Eye Hospitals for the 105th birth anniversary of our founder, Dr. G. Venkataswamy, and for the award ceremony we have in his memory. On this occasion, it is my great pleasure and privilege to specially welcome Professor Astrid Fletcher and her husband, Ion Fletcher, and all the others, her relatives, and all our friends who also have joined us virtually. Professor Fletcher, who is the recipient of the award today, has worked very closely with Dr. G. Venkataswamy in the early 1990s during the famous Madurai IOL study. And subsequently, she was involved in several other studies about which we will hear from others, along with many of us, including myself, the staff at 𝐿𝐼𝐶o, AMRF, all of us know she is one person who had worked with everyone in the Aravind Eye Care System. Dr. G. Venkataswamy, fondly called by us as Chief or Dr. V, is a very patient-centric doctor, is a very compassionate person, and his aim was to provide eye care to all, and that is the reason why we have opened eye hospital in several locations. And each of the locations we ensured that we had a free section as well. In addition, realizing the need to reach everybody, Dr. V was instrumental in starting the eye camps across the whole of Tamil Nadu, which we cover now. And also later, Dr. Nambarmal-Swamy was instrumental in starting the primary eye care centers. It is because of his selfless vision to Today we have 14 eye hospitals, 7 community eye care centers, nearly about 107 primary eye care centers and 7 community centers. And also we have been conducting close to about 3,000 eye camps every year. Through these camps, we are today seeing close to about 6 million outpatients and providing surgical care to about 700,000 patients. And this actually works out to about 17 or 18,000 patients we see daily and about 2,500 to 3,000 surgeries. And with all this expansion, we have been trying to preserve the values with which Dr. V started this organization. And again, Dr. V was extremely a compassionate person. And that is a compassion which made him own all the people who were visually disabled across the world. And that is the reason why he started the Lions Aravind Institute of Community Ophthalmology, and he made sure that we passed on all our best practices to other eye hospitals across the world. And today we have about 370 plus eye hospitals. Practicing some of the value system and the best practices of Aravind, catering to nearly about 1.5 million patients. And the same vision is also made to make the eye care affordable, eye care supplies affordable. Dr. V started the Oro Lab. And in the same spirit, we also got involved into the meaningful community-based research that will enhance the quality of life of the patients, that will make the whole cost affordable, and it's also about how do we improve the access. A lot of these areas is where we have put all our focus, and that is what led to the founding of Aravind Medical Research Foundation, the clinical research, and today we have many papers that have come out of Aravind using artificial intelligence and also point of care diagnosis, a paper that was published recently. So in the month of October, during Dr. V's birthday, which lies on 1st October, we have a series of events during the month of October, starting with the Oration, which usually happens on 1st October. Today, this time, we have preponed it by a day. And this Oration, Dr. G. Venkataswamy Memorial Oration, named after him, is given to the professionals who have given their life for eye care, who have made a significant contribution to community eye care and eye care research. And we are very pleased to have Professor Astrid Fletcher giving this oration. We really thank you for accepting, coming all the way from London to deliver this lecture. And we also have with us Dr. Alan Robin, one of the recipients. We have a few others like Mr. Nagarajan, Dr. Susan also, who were the earlier recipients joining us virtually. In addition to today's oration with which we are starting, we also have few other meetings and workshops which are very dear. The concept of these workshops are very dear to the heart of Dr. Venkataswamy. Today morning we had a meeting on how do we improve our primary vision care services. Today the 107 centers, we roughly see about 3,000 patients, but how do we improve the quality of the services in these vision centers? And again on the Monday and Tuesday, like 2nd and 3rd, we have a workshop on eye research. How do we enhance eye research? Not only us, but many of our partner hospitals, how they can take it up. And we also have a workshop on 4th, where we would like to take the concept of quality in cataract surgery to 10 other hospitals. And 14th and 15th, we have Arangam, a seminar or a workshop, you can call it, a 3-day program for all the mid-level ophthalmic personnel. And we will also have a quality workshop in Aravind Pondicherry, and Aravind Medical Research Foundation is also conducting a skill enhancement workshop on cell culture. So, and there are a lot of these activities happen which are very dear and close to the heart of Dr. G. Venkataswamy. I wish all these workshops and seminars all the success. Once again, I welcome all of you who are here present here physically, and there are a lot of people who have joined us virtually. I really welcome all of them on behalf of Aravind. I also thank all our friends, collaborators, the non-governmental organizations, the community sponsors, all of them for their continuous support to Aravind. Thank you.
An inquisitive pioneer and an innovative personality, Executive Director of LICO, Mr. Tulasiraj, is here to introduce the award winner of the day.
All those who have come here responding to our invitation, both in person and virtually, friends, well-wishers, and my own colleagues at Aravind, it's a proud privilege to introduce Professor Astrid Fletcher, a good friend and a researcher par excellence. There are multiple facets to Astrid, and I'll touch upon the two that I'm familiar with, professional and as a person. I and many others at Aravind have known Astrid over 3 decades, since 1992, if my memory serves right. The initial reason was intraocular lens. With the establishment of OroLab, affordable, high-quality IOLs became available. Many such good things happened with the advent of OroLab, and coming into the orbit of Astrid was one of them, a cherished one. The world then was not in favor of the use of intraocular lenses in the developing countries like India. That's putting it mildly. The policy makers are actually against the use of IOLs. Hard evidence was required to change this perception, since IOLs offered a significantly better quality of vision. A study was then conceived to compare the traditional cataract surgery, wherein the patients received a high-powered thick glasses after cataract surgery with an IOL implant surgery. Astrid joined the research team, bringing in her expertise for studying the impact of these 2 surgical procedures on the quality of life and vision function. This and subsequent studies completely changed the perspective of the governments, World Health Organization, and other international agencies. Astrid then went on to work with 2 other Indian institutions and Aravind to develop an instrument to measure the vision function and quality of life in the Indian context. This multi-centered study, which was the first of its kind, resulted in NVFQ, an instrument with 33 questions. This instrument continues to be very popular and used by several researchers all over the India. I can vouch for this because every other month I would get a letter from a researcher wanting permission and some details to use this questionnaire. Probably the study that most of us in Aravind relate to is the one that established that eye camps served less than 7% of those in care of eye care needs at that point of time. This landmark study galvanized Dr. V to look for other means to effectively serve the community. He experimented different ideas for 4 years, and this finally led to the hugely impactful network of vision centers. These vision centers today handle 1 million outpatient visits a year. Subsequently, there was the INDIE study looking at environmental and genetic risk factors for cataract and age-related macular degeneration amongst the elderly. Dr. Ravindran, who spoke earlier, was so involved in this study that there was a time when no one could eat in front of him without guilt, as he would rattle out the caloric and nutrient values of what they were eating. Astrid's look and size could be very misleading. She is a tough taskmaster and has high standards in how research gets carried out. This brought out the best in the researchers, and then a lot of rigor in the research that Aravind does. She brought the very best in the people, best of people to work with us in different fields, such as nutrition. We had this Alan who came and worked with us, or in air quality assessment. And then she has mentored several of our staff in both in the hospital side as well as in the research side. Now switching gears to Astrid as a person, she's a very warm and caring person. At the same time, she's a no-nonsense person, standing up to what is right. Chitra and I have been fortunate to have become part of her circle of friends. On visits to London, meeting with her and her husband Ian has become a standard. Also on their visits to Aravind, we've enjoyed traveling with them to explore Tamil Nadu's heritage in Pondicherry, Thirukkanangudi, etc. Several of us and Aravind as an institution have a lot to thank Astrid for all that she has done for us and eye care in general. She is certainly in a special place with us at Aravind, and we hope that is reciprocal. Thank you and welcome.
A senior faculty at 𝐿ICO, currently pursuing PhD in Australia, Mr. Sanal Joseph is here to read the citation to be presented to Dr. Astrid Fletcher.
Professor Astrid Elizabeth Fletcher is an emeritus professor of epidemiology, Faculty of Epidemiology and Population Health at the London School of Hygiene and Tropical Medicine. Her extensive expertise spans global health, including roles as an expert advisor to the World Health Organization's study group on epidemiology and prevention of cardiovascular diseases in the elderly, consultations in blindness prevention, and technical advisor to the National Eye Institute, National Institutes of Health, Bethesda, USA. She has also contributed her insights to data monitoring committees for various clinical trials. Astrid was the course director of the MSc in Epidemiology at London School of Hygiene and Tropical Medicine for 5 years. She initiated and developed the distance learning master's course in epidemiology. She has supervised several PhD students from around the world. Her prolific career has yielded over 300 publications, of which 250 are in peer-reviewed journals. Astrid's professional affiliations include memberships in prestigious national and international societies, as well as editorial boards of scientific journals. She was also a member of the planning committee of the Association of Research in Vision and Ophthalmology, ARVO. An avid researcher, Astrid's research focused on the older population and included screening for common disabilities and conditions, randomized trials of hypertension treatment, and epidemiological studies on cataract and age-related macular degeneration. Her research encompasses both etiology and health service utilization of these conditions in the UK, European, and Indian settings. She spearheaded a substantial trial to evaluate the benefits of different approaches to assessment and management of older people in the community in the UK, which was one of the first trials in the country to use the cluster randomization design. The trial not only provided crucial evidence to the UK Health Department, prompting a shift in the policy of healthcare delivery in the elderly, but also facilitated numerous supplementary studies, resulting in more than 50 high impact factor publications. Astrid first visited Aravind in 1992 when she was invited by the National Eye Institute to develop a quality of life assessment for the Madurai intraocular lens study. Recognizing her keen interest in epidemiological research, Aravind's founder Dr. G. Venkataswamy requested her to investigate the effectiveness of outreach eye camps in addressing the eye care needs of the community. In response, Astrid collaborated with a local NGO to study the barriers to eye care utilization in southern India. Employing a mix of survey methodology and ethnographic and qualitative methods, this study revealed that less than 7% of those in need of eye care were utilizing the eye camps. This revelation prompted Aravind to explore innovative approaches to increase the uptake of eye care services in rural communities, leading to the establishment of vision centers. These centers over the years have triggered a paradigm shift in primary eye care delivery, a model widely replicated to achieve universal eye care coverage in resource-constrained economies. 𝐴STID's substantial contributions to the field of ophthalmology extended to two major research endeavors: the Indian study of age-related eye diseases, INDAI, and the European eye study, EUREI. Funded by the GOVEL Trust and conducted across multiple centers, the INDAI study encompassed 7,000 individuals aged 60 years and above in both southern and northern India, with the southern component anchored by Aravind. This study explored the prevalence and risk factors associated with cataract and macular degeneration, which later paved way for numerous supplementary investigations. The study necessitated the development of new methodologies, particularly questionnaires, to assess risk factors. Additionally, it led to the creation of an exclusive software tool named OroNutriSoft for the analysis of 24-hour diet recall data. Being the first large-scale study in India to gather data on blood antioxidants, the INDAI study revealed that there is a robust, independent, inverse association between plasma vitamin C levels and the severity of lens opacification. 𝐴STID had a crucial role in the European Commission-funded EUREI study that demonstrated adverse effects of sunlight exposure on the risk of neovascular age-related macular degeneration to be predominant in individuals with low levels of antioxidants. 𝐴STID played a pivotal role in leading a multi-center study to develop and validate the Indian Vision Function Questionnaire, IND-VFQ, the very first vision-related quality of life instrument tailored to low-income countries. This questionnaire found widespread applications in clinical and epidemiological studies in India and other countries with similar demographic profile. Under 𝐴STID's expert guidance, Aravind designed and executed a randomized control trial to assess the effectiveness of teleretinal imaging-based hospital referral for the identification of diabetic retinopathy among patients attending diabetes clinics, a first of its kind in developing countries. Her contributions extended to strengthening epidemiological and health services research at Aravind. She passed on her passion and scientific rigor in research to every project she took up, and as a person, she was a delight to work with. Aravind Eye Care System is proud and privileged to confer the Dr. G. Venkataswamy Memorial Award for the year 2023 on Professor 𝐴STID Elizabeth Fletcher in appreciation of her immense contributions to research in eye care and unwavering dedication to the field of epidemiology and public health on a global scale.
Thank you, Sanal. May I now request our founding pillars and the guiding lights of the organization, our President of the GOVEL Trust, Dr. P. Namperumal Swamy, and our Director Emeritus, Dr. G. Nachiyar, to come to the dais to present the award. May I also request Mr. Tulsiraj and Dr. R.D. Ravindran to accompany the recipient of the award to the stage. Professor Astrid Fletcher, an Emeritus Professor of Epidemiology, Faculty of Epidemiology and Population Health at the London School of Hygiene and Tropical Medicine, a great friend and a guide to the Aravind Eye Care System, we are honored and privileged to bestow this award on you. May I now request Dr. Astrid Fletcher to deliver the much-awaited oration on working with communities, beliefs and behavior.
I think I'm all right. That's this, yeah. And yeah, actually, yeah, I think. But it doesn't matter. Shall I ready to go? Shall I start? Yeah. Well, thank you so much for that wonderful introduction. And I can't really say how much I'm moved by what's happened today and the previous few days since I came to Aravind. It's great to be back here. I'm so happy. And I know my husband Ian, oh, there he is. He is also very pleased and delighted to be here. I've worked with Aravind, as you've heard, for a long time, since the 1990s. And I really want to put a little bit more flesh on my perspective of how this rather chance encounter brought me to Aravind all that time ago in the context of the MILES trial. So in the 1990s, I was working at the London School of Hygiene and Tropical Medicine, as you've heard. And I was working at that time mainly in studies and clinical trials of interventions in cardiac disease or cardiovascular disease. And at that time, the regulatory authorities, such as the US FDA, and in Europe, the European Medicines Agency, were requiring, mandatory, as part of their approval of a drug or an intervention, they were requesting information on what they we used to call patient-centered outcomes. In other words, it wasn't just clinical measurements or the patient or the view of the clinician, but they also wanted to see what was the impact as reported by the patient. And there are plenty of examples, actually, where I'll give you one from my own experience. I was involved in a trial of a GTN given for people with angina, and they were given a placebo patch, or they were given a patch which constantly gave them some small amount of GTN. And at the end of the day, it was a randomized double-blind trial. At the end of the day, when we looked at the results, we found something that seemed quite extraordinary. The people in the placebo arm fared much better in terms of the quality of life outcomes than the active drug did. So how could that be? It seemed absolutely, the drug company who funded the study simply couldn't believe it. In fact, they were quite upset. We were blind to the codes for the randomization, and they were really quite taken aback at these results. But actually, it wasn't difficult, because what people were experiencing was the headaches that they got constantly by wearing this patch. So for the patient, any benefit on angina was reduced by the constant interruption and interference with their quality of life. And many patients defaulted. They simply ripped them off. So, you know, that's one example that we were discovering, that when you ask people or you measure people's quality of life, then there's a balance between the benefit that might be accrued in terms of some other outcome and the reality of the impact on patients' quality of life. So at that time, as I've said, that's what I was working in. And then one time I was invited to give go to a conference and give a presentation on quality of life outcomes in the context of a number of diseases. And the conference was in Florida, and it was in February. And I thought, well, it might be rather fun to catch a bit of sunshine, because London is rather cold and gloomy in February, so off I went. And a certain Dr. Leon Elwain from the National Eye Institute was there. So 2 days after I got home to London, Leon rang me. He said, we'd like you to take part in this trial that we're going to do in India of cataract surgical treatments, and it's sponsored by the WHO, and we'd like you to help develop the methods. So I explained to him, well, actually, I've never worked in India. I was a bit sad about that, because I would have loved to go and work in India, but I felt I had to be clear to him. And I've also got no experience of developing quality of life measures or patient outcome measures in the context of eye delivery. Well, 2 days later, Leon rang again. And as those of you who know Leon will attest, he can be quite insistent. And so that's how I found myself arriving in Madurai a few months later in Diwali. And I have to say that has been one of the most rewarding and extraordinary experiences. So I'm going to start now with the MILES trial. Is it loaded? So you've heard a bit about the MILES trial, and my job was to develop and validate these new instruments for the MILES trial, vision, function, and quality of life. It was a very, very large study. I mean, incredible resource and incredible efficiency needed, as we see in Aravind, for everything in running this trial. And a very large number of the participants, 1 in 2, were randomly allocated for face-to-face interviews. So as you can imagine, we had to develop the instruments, we had to validate them, and then we had to train the interviewers in order to administer them in a context where a lot of that kind of work hasn't been done before. And basically what the results showed was that there was considerable improvements from baseline in both groups. It was also actually excellent that you might expect in a trial that went on like this, with all these quality of life interviews carried out at baseline 6 months and 12 months, that there might be some attrition. But in fact, there were very high participation rates to the quality of life arm of the trial, and 90% had repeat interviews at the 6-month point, and over 80% at the 12-month, that was the end of the trial. But as we know from what Ravi and have said, is that there was greater improvement in the PCIOL arm. And here you see 𝐕𝐞𝐬𝐽, one of our star interviewers. I hope you're here, 𝐕𝐞𝐬𝐽. I feel you should put your hand up and be applauded. Yes. I don't know how many interviews you did, 𝐕𝐞𝐬𝐽, but it was a lot. And this is a publication in the journal, which showed that actually both arms of the trial, there was an improvement, because of course they've had an intervention, but the improvement was greater in the IOL arm in all these functions of vision perception and of quality of life, and that's shown by the grey bars. So I now want to move on to this a study that's been alluded to by, well, many people, and that's the study which was done in the community. So in the times that I was working on the MILES trial, I had a lot of conversations with Dr. V. And one of the conversations that I had with Dr. V was about the difficulty of getting people to remain, if they've been identified by an eye provider, returning for the intervention. So various studies conducted by different groups in India and also in Nepal identified some of the problems were finance, costs, difficulty of getting somewhere, and there was also the idea of having the 𝐜𝐴𝐾𝐽 motivator. That was also suggested as one of the strategies that could be used to improve attendance and uptake. Well, those studies, which were very useful, really were conducted by the eye care providers. And most of the interviews were done by people who were part of the staff of eye care providers. In this study, we started with a different perspective. We started with the perspective of the community as the most sort of relevant source of information. So this is the study. It was actually funded by the UK Department of International Development, DFID, and we randomly selected villages, 48 villages. I'll tell you a little bit more about how that was done. And then routine eye camps were conducted by Aravind Eye Hospital within 5 kilometres of the selected villages. And neither the hospital nor the camp sponsors knew which were our selected villages. So we tried to make sure they were masked so that it wouldn't influence the way they behaved. And after each eye camp, fieldwork was conducted by speech. This is an NGO with extensive experience in these methods that are used in these kind of studies, usually looking at other practices like agriculture. And that speech had worked before with that. So what they did was do these kind of exercises, which is community mapping. They conducted focus groups, semi-structured interviews, all kinds of other ways of involving the community so that you're starting with the community. And at the end of fieldwork in each village, there was an eye exam by an ophthalmologist from Aravind. And in each village, they spent somewhere in the region of 8 to 12 days in the village doing all these activities. These were not big villages. We had to have a certain optimum size in order to do this kind of field work. I just want to mention Dr. Shanmugam. Dr. Shanmugam took he was responsible for selecting, taking the random selection of the villages using the government census data. He was great, Dr. Shanmugam, because he'd worked, as you will all know, in the WHO smallpox eradication program. And he had the most wonderful stories, usually involving cobras and other terrifying incidents. Luckily, I don't think we had any encounters with cobras in this particular study that we did. This is a picture of the speech team. I'm sorry, it's maybe not quite as clear as it could be. John Debeverum is the tall fellow. He was the founder of the NGO, and these are all his field workers. And as I say, very experienced in working with communities. And you also see Martin Donoghue from the London School of Hygiene, who was the research coordinator who basically coordinated the activities between the hospital and between speech. So this is just a very good example, I think. I know these photos aren't great, and I apologize for that, but I was kind of quite lucky to have got them. This is what they did when they arrived. So they literally draw the map of the village. So here they are. Why is that a good idea? They could come with a map, already provided with where all the households were. Why? It gets everybody interested. What's going on? What are they doing? The kids come, the grown-ups come, Everybody's there, everybody's involved, everybody's excited. Why are they here? And then they marked for every house details of the household. This was all recorded as well, their age, their sex, and whether or not they had an eye problem. That was key information that they were collecting. Some of the other activities they did was to conduct focus groups, semi-structured interviews, exploring what were the ideas of people about eye problems. Did they know what the eye problems were? What were their causes and what were their impacts? So these are now some of the results from the study. So this is what people in the community thought. They identified cataract, blurred vision, and watering eyes. They did know what cataract was, and they named it. They thought the causes of cataract were injury, old age, fever with the rash. I don't know why there was this emphasis on fever with the rash, but there always was an emphasis on the rash, and poor nutrition. And the impacts of cataract were interesting, because they were some very personal, rather upsetting factors, like feeling that you've been teased, facing teasing, feeling sad, feeling that you were not useful, being made fun of. That's what people said. And that information also came from the semi-structured interviews with the key informants of people who had eye problems and who self-identified as having a cataract. For blurred vision, they thought it was old age, poor nutrition. Watering eyes was smoke, body heat, and eye strain. Smoke was obviously a good bet. But they also thought that the impacts of those two conditions was really quite minor, not worth bothering about. So these are the results that I'm going to tell you a little bit more in that detail with, that have been alluded to. So altogether, 749 people reported having, or were identified as having, an eye problem. Of those, 7% had attended the eye camp. Remember, the eye camp went first, so none of the field work done in the villages could influence what had already happened. So in that sense, you can't influence by being involved in field work. Men, and living very close to where the eye camp had been held, meant you were more likely to attend. But then the numbers start dropping again when we come here, because 25 people were recommended to have treatment, either to have their cataracts done or to have refractive errors corrected, but only 13 of the 25 accepted treatment. And of those 51, 26 of the people who came had trivial eye problems. So if you whittle that down to the people you're trying to get at who can benefit in this study, you've gone down to an even smaller amount, maybe 4%, 3%. Now, what about the people who didn't come to the eye camp? Well, these people did have significant vision problems. This is the data from the ophthalmologists who had come at the end of the study and who'd measured, who'd done the vision assessments. So 40% of these people, the great bulk of people who'd been identified by their villages as having eye problems, had low vision, and 7% of them were bilaterally blind. 36%, according to the ophthalmologist at the end of the study, recommended cataract surgery, and 40% required glasses. And this is interesting. People didn't recognize that blurred vision was cataract. So 73% of the people with the symptom, given by the community as blurred vision, actually had cataracts. So that's also quite interesting, I think, for helping to inform communities what the likelihood of getting follow-up for symptoms like blurred vision. We found no evidence for the positive influence of a phakic motivator, but of the 109 previous cataract-operated people, 39% had low vision and 11% were blind. And so, perhaps not surprisingly, when people were asked why they didn't go to the camp, these were the key reasons they give. But one of them was fear of operation, fear of your eyes being spoilt with the words that they used. Now, I should hastily say, these were not all done by you. A lot of these were done by small private clinics in nearby towns. These were not the outcomes of Aravind. But people go to different places to get their cataracts or have an operation. And so obviously that raised the problem of the adverse effect of a bad outcome. And we had a 2-day workshop, which was also funded by DFID, and you'll recognize many of the people in this slide. Dr. Para, Suzanne Gilbert, let me see, GP from Nepal, Dominic Negrel from WHO, quite a large array of people representing different countries, different communities, came to the workshop, and together we spent 2 days talking about them and the implications for their countries and their situation, as well as for this country here. So that really, those 2 studies were the start of my long collaboration with Aravind. And I have to say it's been the most enjoyable and fruitful collaboration, not only because of the studies we've done together, but also because of the extreme and extraordinary personal qualities which I have found displayed by the Aravind family and the Aravind staff, and which really reflect the attitudes and the spirit of Dr. V. And the other thing I have to say about working with Aravind, it's always fun. I am delighted when I come, because people here enjoy themselves. You can be very serious, but there's always a joke and a lightheadedness and a bit of fun as well. Oh, I've discussed that, yeah. So I want to move on now to the section of the... Sorry. I want to move on now. In the many discussions I had with Dr. V, we talked about how early cataract seems to start in India. And also, I was intrigued as to why was there so much cataract in India. It wasn't entirely explained by low rates of operation of cataract treatment. And this is a couple of slides, a slide that's based on 2 papers, using survey data, and critically, these figures include both operated cases and unoperated cases, because if you don't include operated cases as well, you don't get the full picture of the amount of cataract. What you get instead is a measure of the level of cataract service provision. That isn't what you want if you're going to study looking for risk factors. So you can see here that the rates rise very steeply for the age and gender prevalence rates in India compared to the age and gender prevalence rates in Western countries. So that's why this is the sort of second half of my talk. We're looking at behavior, working with communities, but now we're interested in behavior as a risk factor for eye diseases. It could be a risk factor for anything, but in this case, obviously, it's about eye disease. So the questions are, why is there so much cataract in India? What are the risk factors in the Indian context? And critically, are they modifiable? So this is a study that's been alluded to. This is the study, the INDI study, and also the INDI genetic study. And we were fortunate enough to get funding by the Wellcome Trust. And you can see here the teams from the different centres. We've got, Ravi, Thiru, Badri, Dr. Sundaresan for the north, because we have these two centres. We want to have the contrast between the north and the south. Now, India's a huge country. We can't do anything like we did in URI, where we had the 7 centres going neatly down Europe. This would be an enormous study. If you tried to take centres that would be representative of different populations and different practices across India, you'd have a lovely study, but it would cost an absolute fortune, and it would be difficult to fund it. So we had, for the northern INDI study, Dr. G.V.S. Murthy from the RP Centre for Ophthalmic Sciences at Delhi. And as expert advisors, Professor Moraini from the University of Parma, who trained everybody in how to take the photos and grade the lens opacity images. Usha Chakravarti, who's an AMD specialist from Queen's University, Belfast, and myself and other colleagues from the London School of Hygiene and Tropical Medicine involved in different aspects of the study. Alan for nutrition, Liam and Dorothea for genetics. And here's one of many, many review meetings that we had to hold. I think you probably know most of the people here. And I think you've already seen a similar slide. So, just briefly, to describe the study. In the end, we ended up with 6,000 participants, age 60 and over, 85% response rate. I have to say, in most Western countries, getting response rates of that amount is to dream of. But at the moment, it's relatively simple. I think you're in the lucky position of people still being very willing to participate in research. They were interviewed at home, as we've heard, 24-hour diet recall, a lot of work on their socioeconomic factors, work activities, time spent outdoors, tobacco and alcohol use, cooking fuels and stoves. We're probing here which of these might, from, for example, what we know about some of those exposures, tobacco obviously, use of cooking fuels, unclean cooking with dung, cooking with crop residues, very big sources of particulates, very big adverse impact on a number of general health parameters. They then went to the central hospital, which would either be AIIMS in Delhi or Aravind Pondicherry, where they had a range of other measurements. And a blood sample was taken so that we could measure some of the key things we were interested in, like antioxidant vitamins. And also the Buffy coat was taken. And then we added another 3,000 people from the same areas that were enumerated for the first study in the older group. And then the DNA extraction and the genotyping was done by Dr. Sundaresan's group here in Madurai. Now, you've seen this one before, but this is one of the field workers, and they were such great, the field workers. All this data was collected in the home, and it was done before they went to the hospital. And that's important because people are more relaxed at home. If you interview people in the hospital, they're a bit tense. they don't necessarily relax, and you need to have a kind of conversation sometimes. This has also been mentioned before, but I really want to pay tribute to the huge amount of work that has been done to produce this amazing software called Nutrisoft. And I'm only just going to mention what happened in order to provide the data that then gets fed into the software package. So as I said, before the study started, before the main fieldwork started, other field workers went out to collect a whole load of recipes, commonly used recipes. And by the way, that reminds me that I have often suggested, Rami, that there should be a recipe book compiled and made called the Aravind Pondicherry Recipe Cookbook. And I reckon that it would be an absolute sellout, because we knew, even I could have cooked and made some of these, delicious recipes. So if you wanted to know how to make idli and dal or something, it's all there. So I think you should sell it or give it away, or certainly I would promote it. In the main study then, they recalled all foods consumed in the previous 24 hours, structured around meal times, whether it was a usual or a fast day, occasionally you hit. And this is not dissimilar from the kind of 24-hour recall food frequency questionnaires that are conducted in studies in Western countries. And then was the development of software, which was just amazing, using an Access database with individual components, and then they inputted the Indian Council for Medical Research nutrient values per 100 gram of raw ingredient. That allowed you to focus in, for example, we were interested in dietary vitamin C. Well, dietary vitamin C comes from a whole load of the recipes, from the food ingredients. And because it's specific and can only be obtained from the Indian Council for Medical Research tables, it's provided a unique piece of software. Here's one of many discussions about the outputs from the software, and I particularly want to thank Ganesh, who's down on the right there, and Hema, who did a fantastic amount of work on it. And I think that's Tiru leading the discussion. And as was mentioned, we also had a dietary methods workshop, and many international nutritionists also came and participated in that. So just to talk a little bit about the characteristics of the nearly 6,000 people in this study, I'm only going to highlight a couple of items. One of them is vitamin C deficiency. Now that's classically defined as plasma ascorbate less than 11 micromoles per litre, and it's pretty rare in most countries. We saw other indicators of poor nutrition. 32% were underweight. Mid-arm, upper arm circumference is used as a measure of moderate to severe nutritional deficiency. That wasn't too bad, 16% for that. Because it's a predominantly rural population, not an urban population, not a very affluent population, we saw very little diabetes. Tobacco use, we know that tobacco is linked to cataract in many other countries, and we found that mainly quite a high proportion of men were smoking bidis or chewing tobacco, and a surprisingly high amount of women were also using tobacco, and mainly chewing tobacco. And then the other particular exposure that we were behavior we were interested in, was the use of biomass fuels for cooking. And in North India, it's almost exclusively they used cow dung. And in the South India, they used a mixture of crop residues and dung. But what happened, we saw, was we collected this data referring to time periods in the past and currently, and we saw that around a half in South India switched to clean fuels. In other words, they probably had an LPG stove provided by the government. So it was a rather different situation in the South, and a more hopeful one. I just want to go back to the question of vitamin C deficiency. Sanil mentioned the URI study, and what you see here are the mean blood values for blood plasma vitamin C in the different countries. You can see that this is reported, it's all well known, that men have lower vitamin C levels compared to women, but you can see how low they are here, particularly in North India. Even in South India, the levels are dramatically less than the levels in these other countries. I mean, countries that are highest are France, actually, have very high levels, adequate levels of plasma vitamin C. But here you see probably a quite unusual and unexpected finding was that vitamin C levels very, very low in India, in our population in India. So these are some of the publications, and I obviously am not going to go through them. I just want to highlight the ones which relate to the work I'm talking about on vitamin C and about vitamin C deficiency, and also the work on cooking fuels. There were some great publications done by Dr. Sundaresan and his team, but I will have to save that for the talk I will give to his lab next week about the work they did. And just to sort of make a quick summary of what the studies showed, so in this kind of fairly simple table, what we're looking at is taking quartiles of plasma vitamin C, and we're looking at, compared to the people with the lowest, that's the people with the very, very low levels of plasma vitamin C, what was the association with increasing plasma levels on the risk of cataract? So you can see that people who have the highest levels of plasma 𝐜𝐴 in this study, in our study here, had half the risk of having cataract compared particularly to those in the lowest quartile. In the Indi study, we could only use the data for South India, that's the Pondicherry arm of the study, because cooking with biomass fuels with cow dung in the north was ubiquitous. So you can't make a comparison between people who cook with biomass fuels and people who don't, if there's nobody in your study who doesn't cook with biomass fuels. So that's why they don't feature there. This is about the population here in the south. And so it's a simple categorical category. So we're looking at people who always cooked with clean fuels, as I said, probably LPG. Then there were people who had a mix, because in the earlier part of their life, they were cooking with probably crop residues, and then they were switching to clean fuels. And then these are the people who were always using biomass fuels. And you can see there's a nice gradient of risk of cataract according to the amount of biomass fuels. Somebody's had enough. Don't worry, I'm finishing. And you can see there's this nice gradient, but if you always cooked with unclean fuels, you had twice the risk of cataract. So, in summary, what we found with the Indi study, and again, we are concentrating in this talk on behavioral factors, tobacco use, cooking with biomass fuels, and diet, low dietary intakes of vitamin C, and also cooking practices. In fact, because mostly in India, people will cook and heat their food. Maybe they'll make it all in the morning, they'll cook it. But the problem with vitamin C is, and those of you who know what 𝐜𝐴𝐵𝐷 is in England, if you've got a cold, everybody used to rush out and they used to get a sachet of 𝐜𝐴𝐵𝐷, which has got a bit of vitamin C in the sachet, powdered vitamin C, and a bit of paracetamol. And then they poured boiling water on it. But the minute you pour boiling water on 𝐜𝐴𝐵𝐷 or on a lemon, you've killed the vitamin C, it's gone. It's completely degraded. So that is one of the problems, which is, I think, very difficult to see how to address. But basically, the end of having identified risk factors, we then move, not me, probably you, other people, we need to looking for the public health solutions. What should be done then? You know, for example, in England we have now, at last, lowered the rates of lung cancer, for example, from being ridiculously high by strict control of tobacco, increased pricing of cigarettes, and a whole load of preventive measures which depend on good public health. So epidemiology provides the data, but then public health takes it over and looks to see what can governments do, what can health authorities do. And so I think we already see some of it here, because I believe there is already tobacco restriction here. Cooking with biomass fuels can really only be solved by changing to the provision of provisional financial incentives for people to have LPG stoves, and I believe that's already part of the government of India's strategy. And diet, of course, is much more complicated. So, thank you very much indeed for listening to my talk, and thank you very much indeed again for the great honour you've given to me, and for the pleasure I've always had working with you. Thank you.
Thank you, Dr. Astrid Fletcher.
Oh, but I forgot who else to thank. I'm so sorry. My family. And by the way, I don't have that many grandchildren. It's just that I couldn't choose between some of the pictures. So some grandchildren appear several times. But yes, my son in the States, his wife and lovely children, and extended family, my little granddaughter in London, and my little grandson. But without them, I would like to thank them for all the support that they've enjoyed, that they've given me over my years. And a big thank you to my husband. Sorry, did I forget about you? Thank you.
Thank you so much, Dr. Astrid, for detailing the excellent collaboration we've had, the fruits of which we are appreciating and mending our ways of service. And of course, we can understand that you've just not been working, but you've had a great family time too. You truly are inspiring all of us. Thank you so much for the great work that you've done. Dr. Madan Upadhyay from Nepal, a senior ophthalmologist and a close friend of Aravind Eye Care System, has sent a message across to Mr. Tulsiraj sir. It says, as the Memorial Day is approaching, I came across this profound teaching of Dr. V. The goal of life, as Sri Aurobindo taught, is not to escape from the world to some higher heaven, but to transform life on earth into a divine life. This process is accomplished not by the mind, but by surrendering the mind and the vital life forces to the divine, allowing the divine force to work on the body, the mind, and the life forces and to transform them. This is the message he wanted us to read. A sapling planted by Dr. G. Venkataswamy 47 years ago has blossomed into a huge banyan tree today, proliferating in dimensions and directions under whose shade we Aravind members are nurtured. As a mark of respect and tribute to the legendary, a song has been dedicated in Tamil, written by Mr. Prabhakaran, composed and rendered by Sanil Joseph, our faculty at 𝐿𝐼𝐶𝐿.
ஒரு துளி வெளிச்சம் பெரும் வெடிப்பாகும், ஒரு துளி கனவு உலகினை மாற்றும், ஒரு விழி திறந்தால் பல இதயங்கள் பூக்கும், இதயங்கள் பூத்தால் உலகமே சிரிக்கும். ஒரு கனவை நெய்தவரே, பெரும் கனலாய் நின்றவரே, வரும் காலம் கடந்தவரே, பெரும் வரமாய் வந்தவரே. வார்த்தைகள் இல்லை, செயல்களே இல்லை, பயணமோ நெடிது சோர்ந்திடவில்லை, நீர் சோர்ந்திடவில்லை, ஆள்பலமில்லை, பெரும் பொருள் இல்லை, ஆன்மீக ஒளியில் தடைகளே இல்லை. வலிகள் உம்மை வருத்திய போதும், நோய்கள் உம்மை துரத்திய போதும், பிறர் துயர் களைய உறுதிகள் பூண்டாய், பேரன்பாலே பெரும் செயல் செய்தாய். ஒரு கனவை நெய்தவரே, பெரும் கனலாய் நின்றவரே, வரும் காலம் கடந்தவரே, பெரும் வரமாய் வந்தவரே.
Now we have a very special performance. You can just sit back and relax. We have a very special guest today, Sri Kenisha from the Natya Kalalaya, with her guru as Shantini Madam. She is the youngest to perform maximum enumerations in Bharatanatyam, has also been appreciated by the India Book of Records, and has set a new record in international books. Kenisha has been graced as the Ambassador of Goodwill at Gurgaon, Delhi, by the Vishwa Sindhi Seva Sangam in 2023. The piece she's going to perform today is a Padam. The Padam is a leisurely exposition of Abhinaya in the Nritya category with graceful moments. In this Shivtandav piece, Kenisha will be portraying the divine incarnations of Lord Shiva. Can we have Miss Kenisha on stage?
विश्वनाथं भजे सर्वलोकं भजे नादजीवं भजे अग्निरूपं भजे अग्निरूपं भजे शंकर हर हर शंकर महादेव गुरु तांडवम रूप भयंकर सत्य शिवंकर हिमाचल वास तांडवम शिव शिव शंकर हर हर शंकर महादेव गुरु तांडवम रूप भयंकर सत्य शिवंकर हिमाचल वास तांडवम वेद साराय रुद्र तांडवम मंत्र साराय पूर्ण तांडवम शेखराय आनंद तांडवम वेद प्रियाय शिव तांडवम शिव तांडवम संवेदतात्परम एकरुद्राक्ष स्वयंभू आत्मजीविरं नादभूषण ज्ञानतात्परं स्वयंभू राजनिर्मलं स्वप्ननिर्मितं चन्द्रशेखरं स्वयंभू भक्तवत्सलं बलिमूर्ते स्वयंभू संवेदतात्परम् एकरुद्राक्ष स्वयंभू आत्मजीवितं नादभूषणं ज्ञानतात्परं स्वयंभू राजनिर्मलं स्वप्ननिर्मितं चन्द्रशेखरं स्वयंभू भक्तवत्सलं बलिमूर्ते स्वयंभू शिवताण्डवम्
தக்கஜோன் தித் தாங்கிறதுக்கு திரகிறதுக்கு தித் தாங்கிறதுக்கு திரகிறதுக்கு ததிங்கி நத்தம்
प्रिय रुद्राक्षर रूप कैलासगिरिवास लिंगेश्वरा गंगाधर प्रिय रुद्राक्षर रूप कैलासगिरिवास लिंगेश्वरा जगूस समये रुद्रं भज डमरूप संगीत स्तोत्रं जगूस समये वेद रुद्रं भज डमरूप संगीत स्तोत्रं परमेश्वराय शशिशेखराय गुणसाम्भवाय नमः गौरीश्वराय जगदीश्वराय लिंगेश्वराय नमः पंचभद्राय तालनादाय संकीर्तनाय नमः वीरभद्राय सदाशिवाय जगद्गामिने नमः भक्तवत्सलाय नमः अभयप्रदाय नमः सत्यप्रदाय नमः आदिपरं गुरुवे नमः ऋगसरिं निसधनि सरिं निसधनि पद निसधनि पदमव धनि पदमव गम
tataka jana tadim tataka jana jam tatjam targrada targrada tam tataka jana tadim tataka jam tatjam targrada taddi ta kadadak targadom di ta kadadak targadom ta kadadak targadom tang taddi ingena
ஆனந்த தாண்டவம்
Thank you, Tanisha, for that excellent performance. May I now request Dr. Nachiyar Madam to present a token of appreciation to Tanisha. A big round of applause. May you win more and more laurels, Tanisha. I feel incredibly honored and privileged to extend our gratitude on this auspicious occasion on behalf of our organization. Evolution and change has been a constant feature at Aravind, and thanks to our awardee for having steered the organization on several research projects and for highlighting the areas to be improved and challenging us to perform better. Thank you once again. Thank you for also bringing your beloved husband, Ian Harris Fletcher. Thank you, sir, for being with us and honoring us. I thank the management, staff of Aravind Eye Care System and our dear guests for taking their valuable time and ensuring their presence here. Last but not the least, I want to extend a big thanks to our organizing team for making this event happen so beautifully. Thanks to every member of the organization for carrying forward the vision of Dr. V, reminding ourselves that much has been done, but more needs to be accomplished. Thank you very much again. Let's rise for National Anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल वंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।